Good evening, everyone. This is week 5 pre-conference. I did kind of split up cardiovascular just because there's a lot of content for that. It's usually a pretty heavy didactic week. So I am going to use this pre-conference to just go over need to knows for pharmacology for cardiac and vascular medications. Okay, so our first medication we're going to talk about is digoxin. This classification is a cardiac glycoside. The method of action, it increases contractility, so it's going to help strengthen the heart to beat faster. It's a common medication used in patients who have heart failure, and it's going to decrease your heart rate via vagal stimulation. Okay, so if someone were to vasovagal, that is the same vagus nerve that is being stimulated. So uses, like I said, heart failure, and then also for patients who have AFib because of it is a contractility issue going on. Some side effects to look for would be toxicity. That's a big. Did I say big enough? Okay. You need to know signs and symptoms of digoxin toxicity. Okay, so toxicity, nausea, vomiting, halo, vision, arrhythmias. NCLEX tips, you're going to hold if the heart rate is less than 60 and you're going to monitor potassium levels. The antidote for digoxin is Digibind, Digibind. So that should be easy to remember. Digoxin, if you have too much of it, you're going to give Digibind. Okay, one of my favorite drugs to talk about, so I'm going to give you a lot of information on this drug, milrinone. It's a great drug. It is a PDE3 inhibitor, so it increases contractility and causes vasodilation. This medication is used a lot in the ICU setting, or even sometimes a step-down unit if they are able to use it. It's for acute decompensated heart failure. So side effects of this, it can cause arrhythmias, it can cause hypotension because of the vasodilation, like I said. You're going to want your patient to be on continuous ECG monitoring. It's really only good for short-term use and typically only, again, used really in the ICU. So it inhibits an enzyme, and that will increase intracellular AMP in cardiac and vascular smooth muscle. So if it increases contractility, that's going to be a positive inotrope. So that helps the heart pump stronger, okay? And then vasodilation is going to cause the blood vessels to relax. So short-term use, acute decompensated heart failure, when other treatments are not effective. So this is kind of like the last drug that you'll want to put your patients on, just because there's an increased mortality risk if you're using it chronically in patients. So what I want you to think of this drug as the $1 million drug. It's extremely powerful, but it's super expensive, only used in critical care settings and for short-term therapy use when other therapies have failed. Okay, next is nitroglycerin, also considered an anti-anginal and coronary vasodilator. So the method of action is it causes vasodilation, which is going to decrease your preload and decrease your workload of your heart. Side effects, again, you can have a headache, hypotension, and reflex tachycardia with this medication. It's also important you always want to administer this medication with gloves on, because if you touch this drug, it can also cause vasodilation for the person who's administering the medication. So that's important too. For nurses, you're gonna give a sublingual 1 tab every 5 minutes. The max dose is 3 doses max. You want to make sure you take the blood pressure before you're giving each dose, just to check. You'll also want to keep it in a dark glass bottle. It does deactivate with light. And an NCLEX tip, it's contraindicated with patients who take PDE5 inhibitors such as Viagra. Okay, isosorbide, not superly common use, but it is kind of coming around more than the nitroglycerin. So it is also considered a nitrate. It's used for angina prevention, long-acting. It comes in 2 different types. You also don't want to combine this medication with PDE5 inhibitors such as Viagra because it can cause severe hypotension in your patient. Okay, next is beta blockers are LOL, little old ladies. So examples of this is metoprolol, atenolol, and propanolol. The method of action is going to be it will block your beta adrenergic receptors. So it decreases your heart rate, decreases the blood pressure, and decreases myocardial oxygen demand. So these patients, you can use beta blockers on quite a few different disease processes. So hypertension, angina, arrhythmias, heart failure, post-MI. Some nursing considerations across the board will be you're going to monitor that heart rate and hold the beta blocker medication if their heart rate is less than 60 beats per minute. You're going to also use caution with patients who might have asthma or COPD because bronchospasm is a big risk if you're using a non-selective beta blocker. And you're going to taper them off. You don't want your patients to stop this medication abruptly. You can have rebound tachycardia with this. So NCLEX tip, you're going to first check the heart rate and blood pressure before giving this medication. Beta blocker, I want you to think of brake pedal for the heart. Calcium channel blockers. So these are your Cardazems, Verapamil, anything ending in dipine, D-I-P-I-N-E, nifedipine, amlodipine, okay? Make sure you know brand name and generic. There is a chance on your boards that you can get one or the other or both. So it's really important that you are able to know the brand name and the generic name, okay? Method of action for this, it's going to inhibit calcium influx. So it'll cause vasodilation and it decreases the contractility of the heart. So uses for this is hypertension, angina, and arrhythmias such as AFib. Some side effects, it can, again, cause hypotension. It can cause edema in high doses. So a lot of patients, if they're on amlodipine, they're usually on amlodipine 5 milligrams or maybe 2.5. It's rare that you see a patient on 10 milligrams of amlodipine. And the reason why is because it causes widespread vasodilation, which causes swelling to the legs, okay? So some patients may complain of that. They're like, oh, my legs are swollen, and 9 times out of 10, they're probably on a calcium channel blocker at the max dose. So what needs to happen is the doctor needs to adjust that dose down, and then they need to add on a second medication. It also can cause constipation. So verapamil can cause constipation in some patients and bradycardia as well. So nursing considerations, you're going to monitor that BP, you're going to monitor that heart rate. You really should be always taking a fresh set of vitals before you're giving any vasoactive or cardiac medications. You also want to avoid grapefruit juice with calcium channel blockers. So NCLEX tip, hold if the heart rate is less than 60 or systolic blood pressure is less than 90. So for your phrase for calcium channel blockers, if you like kind of the acronyms and the phrases, so smooth muscle roadblock, calcium can't enter. Next is our ACE inhibitors. This inhibits angiotensin converting enzyme, which is going to cause vasodilation and it's going to decrease the blood pressure. So these are the medications that end in pril, so enalapril, lisinopril. Some side effects, you're going to have that dry cough, hyperkalemia, and angioedema. Nursing considerations, monitoring your potassium, and you don't want to use this in pregnancy. For the NCLEX tip for this one, dry cough, you're going to switch your patient to an ARB. So ACE stops angiotensin. Okay, angiotensin 2 receptors. So these are also known as ARBs, or they end in sartan. So losartan, Cozar, you probably know the medication as, but that is one of the medications, one of the ARBs that is commonly used. So method of action, you're going to block angiotensin 2 receptors because it's going to cause vasodilation. Uses are heart failure and also hypertension. Some side effects that you may see in your patients, hyperkalemia, angioedema. You'll see this, it's less common to see it in an ARB than in an ACE inhibitor, but you may see it still in an ARB, so just keep that in mind. No dry cough likes ACEs. Okay, so that's your NCLEX tip. No dry cough likes ACEs. Okay, next we're going to talk about alpha adrenergic blockers. I will split this slide up into two. So they're drugs that block alpha adrenergic receptors, which are part of the sympathetic nervous system. So go all the way back to A and P, okay? So they're classified by receptor type. So you have alpha 1s and then alpha 2s. So your alpha 1 adrenergic blockers, doxazosin, terazosin, tamsulosin, so that's BPH specific. The mechanism of action, it's going to block alpha 1 receptors on vascular smooth muscle. So that will cause vasodilation and it'll decrease blood pressure. It also relaxes smooth muscle found in the prostate and the bladder neck, which is why it's good for improving urine flow for BPH. Other uses other than BPH is Raynaud's disease. Occasionally you'll use that and hypertension as well. Side effects, orthostatic hypotension for the first dose effect. So that's key teaching for your patient to arise slow and change his position slow. Dizziness, headache, reflex tachycardia, and nasal congestion. So you always want to give the first dose of an alpha 1 adrenergic blocker at bedtime to reduce that first dose hypotension I was talking about earlier. You'll teach the patient to change positions slowly to prevent falls. You'll want them to monitor their blood pressure twice a day and then monitor for palpitations or syncope. So NCLEX tip, alpha 1 blockers relax the arteries and the prostate. First dose hypotension is a classic NCLEX test point. The next category we're going to talk about is alpha 2 adrenergic blockers. So they're technically receptor agonists, but sometimes we're going to kind of keep it all together just so you guys can understand that there's alpha 1, alpha 2, because they do affect alpha adrenergic pathways. So I'm going to include it just so you guys are aware, because it was in your didactic that you were responsible for. So some examples of this is clonidine, methyl-dopa. The mechanism of action, it stimulates alpha 2 receptors in the central nervous system. So that's going to decrease sympathetic outflow, decrease the blood pressure, okay? So uses, hypertension, okay? Clonidine is used for hypertension, for alpha 2 adrenergic agonists, and then methyl-dopa is actually used in pregnant patients, okay? Side effects, sedation, dry mouth, you'll have those anticholinergic effects, rebound hypertension if it's stopped abruptly. And NCLEX tip for these drugs is you can't stop these abruptly because it can cause dangerous rebound hypertension, okay? So dangerous rebound hypertension will occur if you stop these medications abruptly. Okay, next we're going to talk about arteriolar vasodilators. So some examples of this would be hydralazine. The method of action, it's going to cause direct smooth muscle relaxation, which is going to decrease your afterload. Some uses are in patients with heart failure and severe hypertension that might not be responsive to the typical like ACE inhibitor or ARB, which is typically a first line for hypertension, or a calcium channel blocker. Some uses are severe hypertension, heart failure, and you're going to watch for lupus-like syndrome with hydralazine. Your patient may complain of a lupus symptom, so that's something to keep in mind. Okay, anticoagulants. Heparin is a short-term anticoagulant, so you're going to monitor APTT, and the antidote for heparin is protamine sulfate. That's something really important that you really should know. And warfarin is going to be your long-acting anticoagulant. You do have to monitor the INR, so the patient does have to go to for blood work or like a clinic weekly. The antidote is vitamin K. Your direct oral anticoagulants, Eliquis, Xarelto, no routine labs are needed, so sometimes you have better compliance with these medications. Nursing considerations, of course, bleeding precautions, no intramuscular injections, soft toothbrush. They shouldn't be really doing a lot of like rigorous activity, like someone who's on blood thinners probably should not be skiing, things of that nature. So just think of activities and other precautions that you want them to take into consideration. So NCLEX tip, heparin equals the hospital, warfarin equals home. Okay, antiplatelets. So these medications prevent platelet aggregation. So some examples are going to be aspirin and clopidogrel, which is Plavix. Method or mechanism of action is it's gonna prevent platelet aggregation. Some uses are in MIs, stroke prevention. If someone has a stent placed, they'll use it for that as well. Nursing considerations, again, you're going to monitor for bleeding and you're going to want to make sure the patient holds this before surgery. NCLEX tip, platelets equals a plug. Antiplatelets prevents the plug. Thrombolytics, it's all in the name. So examples, TPA, Restiplex, a method of action. It's going to dissolve existing clots. So this is used with ischemic strokes, not hemorrhagic strokes. And that is going to be a key indicator whether you're going to give antithrombolytics or not. So if it's a stroke, you're going to want to give this medication within 3 to 4.5 hours. You can give it in a massive PE like a saddle PE or a myocardial infarction. Some contraindications for thrombolytics are recent surgery, hemorrhagic strokes, if they've been in like a recent car accident, that puts them at increased risk for bleeding risk and severe hypertension. So for your NCLEX tip, thrombolytics, you'll just want to know the last known well time for the stroke because that's going to be a key indicator whether you can give that medication or not. Okay, last medication class we're going to talk about is anti-cholesterol agents, also known as lipid-lowering agents. So statins, you'll usually want to give those at bedtime. You want to monitor liver enzymes and muscle pain because your patients are at an increased rhabdo risk. And honestly, it doesn't matter if the patient's really been on the med for short term. I've seen rhabdo in patients who just started the med and they were on it for a couple months. And then I've seen rhabdo in patients who have literally taken the med for 25 years and then all of a sudden they're having an issue, okay? If they're on niacin and they're complaining of like a flush feeling, you're going to want to give them aspirin before giving them the niacin. Bile acid sequestrants, they can cause constipation. You'll want to take that with water. And for the NCLEX tip, muscle pain, plus an increase of CK, you're going to want to stop the statin because you're going to run the risk of putting the patient in acute kidney injury and they'll have Coca-Cola urine and you'll be like, oh my gosh, what's going on? The patient has rhabdomyolysis. Hopefully that was helpful. I tried to keep it brief and just give you the need to know. If you're having issues with, memorizing pharmacology, I know it's a lot. I got pharmacology cards offline, and I would just do flashcards. That was honestly the easiest way for me to like keep the meds apart. And I drew a lot of charts and tried to learn all of the drug classes. Good luck this week and have a good weekend.